Dr. Stephen Reichbach, welcome to the podcast.
Thank you. Very happy to be here.
So I understand you've been running a ketamine clinic in Sarasota for the past 7 years. And ketamine is a really intriguing, interesting kind of a treatment. Can you tell me a little bit about what you do and what kinds of conditions you're able to treat with ketamine?
Sure. So we've been here about 7 years or so treating patients with intravenous ketamine. It's really two subsets of patients. The first are patients with certain mood disorders, more specifically, patients who have been dealing with significant depression, anxiety disorders. Very often, they've been diagnosed with PTSD, or there's some sort of trauma in their history that might not have officially been diagnosed as PTSD. They have typically been on medications for a number of years that either haven't worked or haven't worked for any significant period of time. The patients just don't tolerate side effects, and they are still struggling with whatever the symptoms of their depression, anxiety disorders are. And ketamine has been a very effective alternative treatment for many of them. It works by a completely different mechanism of action than any of the oral medications, the SSRIs, mood stabilizers, and such. So that's really one subset of patients. And the second subset of patients that we're treating are patients with certain chronic neuropathic pain syndromes. And when I say chronic pain syndromes, we're talking more about conditions that involve central pain as opposed to peripheral type neuropathic pain.
Oh, okay. And do you have a background in either psychiatry or anesthesia or pain management? Like, what's your background before using ketamine or treating with ketamine?
Well, I've been using ketamine for about 30 years. I'm an anesthesiologist and was a practicing anesthesiologist in New York, so very familiar with ketamine for many purposes. Ketamine itself's been around for about 50 or so years. It was invented as an anesthetic, and probably over the last 15, 20 years has been researched quite extensively and studied for its very powerful antidepressant effects. So that's the first thing. Second thing is we've been treating patients with intravenous ketamine, completely different protocol to treat many of these chronic pain conditions. The condition that's been studied most extensively is a condition called CRPS, or complex regional pain syndrome, which also used to be referred to as RSD, or reflex sympathetic dystrophy. That condition is a horrible, horrible condition that a certain subset of patients can get, and very often ketamine is the only thing that will help them to any significant degree as far as their pain and function.
Okay, and that's, yeah, RSD, or the complex regional pain syndrome, fits in an interesting category of conditions which at some point in history, they were difficult to prove that a patient had them, and maybe doctors didn't believe their patient was being honest, maybe they thought they were malingering or being hysterical. There's that one, and then there's also fibromyalgia, and then more recently there's patients who are going through protracted benzodiazepine withdrawal, and maybe withdrawal from other psychiatric drugs, or the antidepressants and things like that. And sometimes in these protracted withdrawal syndromes, patients will complain about these non-specific severe pains. They may have pelvic pain, headaches, chest pain, just pain, or maybe just a general feeling of pain, or akathisia, where they just can't stop moving and they just feel like they want to rip their skin off, and they just feel this horrible pain and hopelessness, and it can make them suicidal. Have you worked with patients like that? Have you seen any positive results with ketamine?
Absolutely. The majority of patients that we treat, they've been on medications for a long period of time, many times, as you alluded to, SSRIs, narcotic, benzodiazepines. As a result, these kinds of medications are extremely difficult to wean off of, and need to be done extremely slowly, where patients start to develop, severe side effects or severe withdrawal symptoms from them. And the withdrawal can manifest in numerous ways, as you alluded to, pain, vague pain or pain that doesn't make sense. And the conditions, a lot of the conditions that we treat for pain, you know, patients have been to neurologists and pain management doctors, and they've been tried on, a million different medications and different nerve blocks and treatments. And sometimes there's no explanation for the pain that they're describing or that they're experiencing, and they're sort of, the doctors get frustrated and they don't understand the patients don't understand why the doctors can't, do more to try to figure out what's going on. And whether patients are referred to us or they find out about this option sort of on their own, very often ketamine can be an extremely valuable tool. When I say central pain compared to peripheral pain, well, central pain is really pain that emanates from the central nervous system, the spinal cord and the brain. And so when patients come or they're referred to us and they've had a million MRIs, they've had all kinds of lab work, nerve studies, muscle biopsies, and the pain is still way out of proportion than anything that you can sort of pinpoint or identify. A lot of times that pain that's above and beyond is what we refer to as central pain. And that's the kind of pain that ketamine can be extremely, extremely effective in treating. Oftentimes, patients that we see, there's really a very fine line between dealing with chronic pain and mood disorders. Those pathways are very closely linked. And when I speak to a patient initially and they, I ask them, what is the primary issue? Is it, your migraine headaches, or is it this abdominal pain that nobody's been able to identify, or this back pain, or that kind of thing? Sometimes they can't even tell me what is the more pressing issue, which happened first, what, if we could help one, will it help with the other? And very often we'll approach it from one aspect of the other or the other because the protocols are completely different. And if the primary issue is a chronic pain issue and they describe that they've been on antidepressants for a while, they can't remember if it's before the pain started, after the pain started. We will get some indication very often if they come in for a chronic pain issue. Many times the depression lifts, the anxiety level goes down, they start sleeping again, and vice versa. So though the protocols are different, we can get a lot of information with either protocol in trying to figure out if it will help the less urgent issue.
Okay, and I was curious. I think what you do, I think, is ketamine infusion, which would be giving like an IV ketamine through a intravenous line. But how does
correct.
that? And thank you. And how does that differ from this new drug, S-ketamine, Spiriva, the thing that psychiatrists can now give the FDA-approved nasal spray? Is it a different drug, or are they similar?
They're similar, but completely different. Really, S-ketamine or Spravato that you mentioned, there's two isomers to a ketamine molecule. There's an R isomer and an S isomer, and the S isomer is really the Spravato or the S-ketamine. S-ketamine was produced or manufactured because it was able to be FDA approved. Ketamine itself has been around such a long time; it's been off patent for 20, 30, 40 years at this point. So in order for a medication to be FDA approved, it's got to go through extensive testing and research and studies over a number of years with long-term outcomes. And there was no money really to be made from pharmaceutical companies to finance a lot of these studies because there was no golden ticket at the end of getting FDA approval for ketamine, since it's been off-label. Pretty much any pharmaceutical company can produce it at this point. So they came up with S-ketamine, which is a half the molecule of ketamine, and they came up with a nasal spray and a protocol for patients to use as an antidepressant. They're just using S-ketamine at this point as an antidepressant. Comparing it to the ketamine that we use intravenously, first of all, the majority of studies that have been done over the last 15 years to treat depression have been done with intravenous ketamine. Intravenous ketamine has a lot of advantages. Mainly, we talk about bioavailability, and bioavailability is really the actual amount of drug that goes to where it has to go and does what it has to do. When you use a drug intravenously, we know that 100% of it is getting to the area where it has to go, to the brain in this instance, let's say. It's not being metabolized in the liver before it gets to the brain. You're not concerned that it's getting absorbed through the nasal mucosa or the oral mucosa. When you're using a nasal medication or an oral medication or a sublingual medication, you and I could take the same dose, let's say 50 milligrams. With other variables involved, you may absorb 60% of that medication. I may absorb 80%, and somebody else may absorb 40%. So it's very difficult to say exactly what dose a patient is either responding at or not responding at. With intravenous ketamine, if a patient comes in, I give them 50 milligrams through an intravenous. I know that 50 milligrams precisely is going where it has to go. If a patient doesn't respond at 50 milligrams, there's really no ceiling as to what dose we can go to try to elicit a positive response in the patient. If I decide to go to 70 or 80 milligrams and they respond, I know that 70, 80 milligrams precisely is exactly what dose they responded at. And there's some consistency with individual patients as to what dose they will respond at on a pretty consistent basis once we get there. Second thing is, when you use a nasal medication or oral medication, there are psychomimetic effects that these medications can cause. They're mind-altering drugs, even at low doses, sub-anesthetic doses, which is how we are using them. And patients can get uncomfortable with that dissociation. And so once you use a medication orally or nasally, you're sort of married to that medication until it is metabolized and wears off and becomes a lesser concentration in your blood. When we're using intravenous ketamine infusions, we keep a very close eye on patients, and they're able to talk and communicate. And if they describe uncomfortable feelings with the dissociation or something that's scary, it's a very simple fix. We turn the infusion off for a couple of minutes, or we slow it down. We give a medication that acts as an amnestic, so that it kind of calms them down, takes away that anxiety. And within a couple of minutes, the medication is metabolized and they're back to being grounded to where they're at a comfortable point, at which point we can restart the infusion at a slower rate so they're not getting such an intense feeling of dissociation with the intravenous method. So to me, I'm sort of biased towards, if patients are really struggling and they're trying to figure out if ketamine is something that will be effective for them. For me, I think really the only way to do that effectively, for the most part, is with intravenous infusions.
Yeah, that makes sense. I was wondering about, everybody's so interested now in psychedelics and psychedelic therapy. There's psilocybin, MDMA, ibogaine. There's just an explosion of all these different psychedelics that everybody's in a rush to get them approved and be able to use them in treatments, and they're doing studies. But like you said, ketamine's been around really forever, on the time scale of pharmaceuticals, and it's very well known. But would you classify ketamine as a psychedelic?
They are actually really considered different classes of drugs. Ketamine itself is in the class of drugs as PCP or phencyclidine. It's considered a dissociative. Yes, it's a mind-altering drug, but it's not, more specifically, not considered a so-called psychedelic. Are some of the experiences that patients will describe similar to psychedelic drugs? Absolutely. It's sort of a fine difference, but they are technically classified as different types of drugs.
Okay. And when you treat someone, do you get them into that, do they actually get into that state of disassociation where they might have some kind of a I don't know what to say, like an inspired feeling, or feeling disassociated from their body, maybe saying like, wow, I'm, maybe seeing life from a different perspective, or
Absolutely.
seeing, like, how would you describe like that kind of how a person describes coming out of a treatment?
Sure. So let me just kind of clarify. The as far as ketamine goes, and this is different than how we understand the psychedelics at this point. And there's a lot of misinformation and you know stuff out there that you may read about. As far as ketamine goes, at this point in time, what the research behind it has shown is that it's not so much the experience that patients go through that's ultimately responsible for improvement in clinical situation in function, lifting of depression and anxiety. Um, Ketamine is known to cause physical changes in the brain. It jumpstarts these chemical cascade of events that cause physical changes and uses the brain's ability to sort of reform itself and grow. And uh, what it does is it causes a strengthening of the dendritic spines. The dendrites are the connections between the neurons. And in the mood centers of the brain, within an hour or two of receiving a ketamine infusion, these changes start to occur. And from what we understand, that improvement in dendritic spines, lengthening, strengthening, improvement of the synapses, which are the spaces between the neurons, and being able to transmit neurotransmitters more effectively, that we know is caused by ketamine at very low sub-anesthetic doses. And what the research has shown is it's these physical changes, these hardwired changes in the brain that are ultimately responsible for improvement in mood and function in a relatively quick period of time. So we may see patients with a dramatic improvement after only one or two infusions. And we, for the most part at this time, we attribute that to these physical changes. There are patients who will describe to me that they go through the infusions and they're very comforting and nurturing and transformative, and they have this clarity that they've never experienced before having gone through these infusions. And you know I am sure that there is something to that. There's no question about it. And so I'm happy to provide that and allow them to go through that experience. Um, but for me, it's more just getting this certain determined dose of ketamine in that I hope will elicit these physical changes that I'm most concerned with. We see a large number of patients who have been through extensive trauma, childhood trauma, the most horrible things you can imagine. And their main concern when they come in for ketamine infusions is they don't want to be taken back to those traumatic, terrifying, scary times, which is certainly possible when you undergo a ketamine infusion. And I reassure them that they don't have to. We don't have to get to that point for this to be effective. And so, how do we go about treating those patients? Well, if I give you 50 milligrams, 60 milligrams, 100 milligrams of ketamine, whatever the dose is, and I give it to you over 1 hour, it's going to be a completely different experience than if I were to give it to you over 2 hours. And so, in order to keep patients grounded and so that they don't feel any kind of intense dissociation or something that's going to ultimately be scary for them, we tailor the infusion so that we make it so that they don't dissociate to any significant degree, and they can comfortably go through the infusion and feel more or less like they do when they come in that day, without any psychomimetic effect from it. And their response will be a positive one to the same degree that it would be as if they, had a full-blown dissociation and that kind of thing.
Okay, it almost seems like, and I don't know if we know anything about this, but is it possible that a person might benefit from a very low dose of ketamine on a regular basis? Like, and I know it wouldn't be practical to go in for an IV infusion every day or every other day, but maybe if a person could take like a sublingual, very low dose, like 5-10 milligrams or something daily, is there any possibility that would be beneficial, or we just don't know that?
Sure. So the protocol I follow is to do initially six infusions, and we try to do them within a 2 to 3 week time frame. Um, for patients who get my expectation is that at some point after those 6 infusions, patients are going to start to sort of regress and slide back with their symptoms. I expect that. I don't expect the majority of patients that we treat, and we keep in touch with pretty much everybody. We have patients that have gone through 6 infusions and we've never had to see them again. And we've kept in touch and they've done extremely well. The majority of patients do need to come back periodically, especially over the first year. And there seems to be some consistency as far as how long they get a benefit from this for. And so the idea is to try to stay ahead of it and figure out how long individual patients will benefit from those initial 6 infusions. To answer your question, for patients that we find only seem to get a 3, 4, 5 week benefit or response from the infusions, I will prescribe sublingual ketamine troches for them to use in between infusions. And really, you're not going to have anywhere near the same dose or the same effect from those lozenges or troches that you're going to feel during an infusion. But it seems to extend the time frame between infusions that patients need to come in. Just by keeping those receptors sort of primed without the psychomimetic effect, seems to lengthen the amount of time that patients are able to benefit from those infusions. And so I don't generally prescribe it for patients who seem to get 2, 3, 4 months of relief through the infusions over the first year. And after the first year, that time frame just seems to get longer and longer until we just basically don't need to see those patients anymore. They've done well. And there's probably some cumulative effect to it. But we use it more so just to lengthen the time that patients are able to get that benefit from these infusions.
Okay. And now there's been some concern about negative effects or adverse reactions to ketamine, which my research on it, just reading up on it, it seems to be one of the safer drugs or safer medications out there. But there is some concern about, I think, damage to the liver, bladder damage, increased suicidal ideations, depression. And I don't know if some of these might be related specifically to S-ketamine. So I'm not sure if what I'm looking at is specifically about that or ketamine. And just, and also, I mean, have you had issues with people having respiratory depression, having to intubate them during treatment, or any, major issues during the procedure?
So to answer your question, ketamine is an extremely safe drug. Yes, it's metabolized in the liver. Unless a patient has an active liver process going on, they have a flare-up of hepatitis, or they're really end-stage cirrhotic, where they've got no liver whatsoever to metabolize anything. The sub-anesthetic doses that we're using is probably less toxic to the liver than taking 2 Tylenol, in my opinion. You will hear about a condition known as hemorrhagic cystitis, or basically where the bladder, you get holes in the lining of the bladder and heavy bleeding. We have never seen it. We've never had a patient who's developed hemorrhagic cystitis. The people who develop hemorrhagic cystitis from ketamine are people who have been abusing it super high levels on a daily basis for long periods of time. We treat patients with these chronic neuropathic pain syndromes at doses that are 10 to 20 times what they are for mental health. And these patients will come back 4 or 5 days in a row at super high levels of ketamine. And we have not had any issues with anything related to hemorrhagic cystitis or other bladder issues. And so for me, the threshold to try ketamine on patients who are struggling at the doses that we're using, unless you have your liver enzymes are actively elevated and continuing to go up, or you're completely cirrhotic and I need a gastroenterologist to tell me that it's safe to give you 50 or 60 milligrams of ketamine. Who do we not give ketamine to? Well, patients who have been diagnosed with psychosis or delusional for whatever etiology, and they're actively in a psychotic or delusional state. Or patients who have been diagnosed with bipolar disease and they're in a hypomanic or manic phase, we would avoid ketamine because ketamine is thought, even at low doses, to potentially worsen those conditions. Um, I would tell you that every patient that we treat needs to um, be treated, actively treated with a mental health care professional. I'm not a psychiatrist. I'm not a psychologist, but I've been using ketamine for obviously over 30 years, and that my skill set is with administering ketamine safely, and we've treated, you know, probably 12 to 1300 patients for mental health issues with ketamine, with intravenous ketamine. And so I've seen quite a bit, and I'm very familiar in how patients are responding and if patients are having a negative response to it. And so, it's important to stress the fact that patients do need to be plugged into a mental health care provider while they're undergoing, and even more so once they're starting to feel better from the ketamine treatments. Most patients will describe feeling that they're able to benefit more from therapy or counseling once they get to a point where they become more receptive to it from the ketamine.
Okay, and oh, just to follow up, I think I threw way too much stuff in that last question. Do you ever have, are there any, and now if someone were to have an emergency during the procedure, say that someone did need to be intubated to
Sure.
be put on a ventilator, that's probably rare, probably never happens. But if it were to happen, of course, who better to be administering it than an anesthesiologist who's done that a million times?
100% with that one. We have all the resuscitative equipment here. Um, we have laryngoscopes and endotracheal tubes, LMAs. Um, we have never had to put an artificial airway in a patient here. Um, Ketamine itself is extremely hemodynamically stable. You will see bumps, increases in heart rate and blood pressure during the course of an infusion oftentimes. There's very little in the way of respiratory depression. We're obviously monitoring patients' oxygenation. We have pulse oximetry and blood pressure, monitoring blood pressure and EKG. And so the ketamine itself is extremely hemodynamically stable, is extremely stable respiratory wise. So unless I get very concerned more so with the pain infusions where the doses are higher, and if patients, if they're obviously on home oxygen or their respiratory status to begin with is sort of tenuous, we're very careful in trying to select patients that are going to be higher risk and may not be safe to do here in the office, as opposed to maybe more in a more hospital-based setting to do these infusions. Although we've never had an issue here, to be honest with you, as far as any kind of decompensation of patients. My concern more so is the dissociation and how patients are tolerating the dissociation side effect of the ketamine, more so than the respiratory or the hemodynamic the majority of times.
Okay, and I read an article a long time ago, and I don't know if this is if it's used for children, but there was an article about how ketamine might be an ideal anesthetic for children getting emergency room procedures, rather than giving them traditional other kinds of things. That ketamine is very well tolerated with children, but they said one of the worst side effects that the kids get is nightmares after the treatment. I don't know if that's like a problem, usually for adults at all.
That is something that can happen. Nightmares, especially going through the course of the infusions, we do hear that probably in about 10 to 15% of patients. It's not a common occurrence, but it is something that I do talk to patients about, before they undergo the infusions. And there are certain ways to minimize, that incidence for happening. But again, as you mentioned, ketamine is a wonderful drug for kids. again, because it's hemodynamically stable, very little in the way of respiratory depression. And so, whereas older people, adults may get uncomfortable with the dissociation or the experience of what ketamine can do, even at relatively low doses, most kids like seeing elephants walking on the walls and different colors, and they're not unnerved by it. And so, you really don't run into the same issue with kids, oftentimes that you do with adults. Just to kind of put in perspective, the kinds of doses that we're using to treat these mood disorders, I tell patients, if you fall and you dislocate your hip or your shoulder and you need to go to the emergency room and they need to reduce it, they need to put it back in place, they may very well use ketamine, even on an adult, to sedate you to be able to do that, because ketamine itself is an amazing analgesic. It's stronger than morphine. And again, you're not as concerned about respiratory depression or desaturation and dropping blood pressure. And so ketamine would be a good option for a lot of those types of patients. And the dose of ketamine that they would likely give you would probably be 2 to 3 times what you would get initially here over an hour, for an infusion to try to treat a mood disorder. So that kind of puts it in perspective. When patients are concerned, hey, am I going to have a crazy hallucination? Is it going to be out of control? Am I going to be terrified? When I present it to them like that, it sort of eases their mind and puts things in perspective. So that's kind of the thought process behind that.
Okay, and you mentioned comparing it with having an analgesic effect superior to morphine, and there are some recent articles about ketamine possibly having opioid-like properties. Is that a concern, or is that true or an issue at all?
Well, that again is one of the reasons that I sort of have a preference for intravenous as opposed to intranasal. So the first binding effect of ketamine when you're using it intranasally is to bind to opioid receptors in the frontal part of the brain. And so that's a short-lived effect, but it's a real effect. And patients who might have a propensity for, they've had an issue with opioid dependence or opioid addiction before, really have to be careful with that, even though it's a short-lived effect and it's not responsible for the longer-term benefit of ketamine, forming those new pathways and those physical changes in the brain. You do get that feeling of euphoria initially, and whether it lasts a couple of minutes or it lasts during the course of the infusion, longer term. We've never had a patient or an issue with a patient becoming dependent or abusing ketamine going through these intravenous infusions. I think the likelihood of dependence or becoming addicted more to it, more likely with the nasal ketamine.
Okay, oh, that's interesting. And just one final topic.
Sure.
Have you seen have you treated patients with alcoholism or drug addiction and seen some good results of them moving forward towards recovery or helping with the recovery with ketamine treatment?
Absolutely, but maybe not for the reason that you're alluding to. There's very little data out there as far as using ketamine, to get patients off alcohol or certain types of drugs. What the ketamine really does is it helps to deal with the underlying issues. So if patients are self-medicating and they're using alcohol to help with their depression, anxiety, ability to function, or opioids to, in that respect, or they've become dependent on opioids. What the ketamine hopefully will do it'll deal with the underlying depression or anxiety disorders, which should, secondarily help patients, decrease their need to self-medicate with those substances. Having said that, I would tell you that, as you can imagine, the majority of patients that we see have some dependence on alcohol or other types of drugs that they've been on for a long period of time. And almost, more so anecdotally, though there are some small studies out there, patients, especially with alcohol type issues, going through these infusions without even realizing it, oftentimes their alcohol intake will decrease. And patients who are coming in more so for pain and they've been on high doses of narcotics, it seems like we're able to wean them down off of their narcotics with minimal withdrawal effects going through these ketamine infusions. And part of it may be that you're helping with their pain level going through the course of these infusions. So if they're taking medication only as needed, it becomes a lot easier for them to completely stop that. But also patients who are taking standing orders of narcotics, it seems like we can more rapidly wean down to a lower level without having to deal with side effects or withdrawal type symptoms from that. And I think that down the road, this is the tip of the iceberg in using ketamine and probably other types of similar medications, as you mentioned before. I think the down the road, this is going to be the future of trying to deal with addictions and dependency, and obviously PTSD and mood disorders and depression, and probably pain as well. With a lot of these other substances, and the mechanism of action needs to be researched and studied, and who do we do this for and who do we not do it for, and what are the protocols. We know that to a large degree with ketamine right now. And so to me, when we first started treating these patients, it was a much more narrow criteria as far as picking and choosing which patients. It had to be patients who had been on at least 2 or 3 antidepressants and failed them. They had to be labeled really treatment resistant. My threshold at this point, 6.5, 7 years later, is much lower to try to help patients who are struggling, only because the downside is really so little other than not working, and the potential upside can be quite profound. We have treated, this is the last thing, I know I'm throwing a lot out there, but we've treated patients who have gone through a rapid opioid detox, and they follow up with us once they go through this rapid detox, and they'll come in once a month or once every couple of weeks with infusions, and it seems to be extremely effective in preventing them from falling back into whatever addictive patterns they had been in before. And so the negative patterns, the recircuiting or the regrowth of different parts of the brain, we don't understand it completely, and certainly it needs to be researched further. But from my experience in treating, hundreds of patients, there's really something. There really seems to be something to it.
Okay, well, that's incredible, and that's also a major thing. If there's some way that it can help people with the healing process of tapering, even people who have gone through like a year or more of opioid dependence treatment with buprenorphine or Suboxone, and now they're worried about how do I get off of that.
Sure.
Maybe that tapering process is difficult. So yeah, if ketamine treatment infusion can help with the tapering process, that's incredible. And addiction, trauma. How can people find you, Dr. Reichbach, if they're interested in, looking into this treatment?
Absolutely. So I can give you the phone number here. It's 941-213-4444. We have a website, findpainrelief.com, with a lot of information, useful information, research, articles, and resources. Honestly, I spend half my day talking on the phone with people who are just curious about it, prospective patients, family members, if this is something that might help them. And I'm happy to talk to them, and sort of explain the process, hear their story, and try to figure out if it's something that might help them. We're extremely accessible here, and so we're just trying to spread the word and get the word out there that for patients who are really struggling, and there's a real crisis in this country at this point with mental health, and the typical medications may be effective 50 to 60% of the time, but what's happening with other patients? They need to be, know that there's other options out there, other alternatives. When we first started doing this, I would say the patients that were inquiring and that we were treating, it was probably 90 to 95% self-referred patients. At this point, over the last few years, it's probably become more 75, 80% referrals from psychiatrists and counselors, therapists, mental health care providers who have seen how effective it's been for their really hard to treat patients. And they've sort of let their guard down now, and they'll call me, or they'll have patients call me, and there's a much better communication circle now with the mental health care providers, and they're interested in it, and I'm happy to talk to them and describe the process to them as well.
Oh, wow, that's great. Dr. Stephen Reichbach, thank you for joining me on the podcast today.
Oh, it's my pleasure. It was nice meeting with you and speaking with the people out there.